of the co-leads. I'm one of the co-leads for the Canadian Cancer Survivorship Research Consortium, along with Armini Kazanjian in BC. And today I'm happy to be presenting with my master's student, Lauren Quirk, who is with our program here at Princess Margaret, the Cancer Rehabilitation Survivorship Program, and a master's student at University of Toronto. So we're going to be sort of doing a little bit of a tag team here. I'm going to, Lauren's going to start with some background, and I'm going to jump in the middle, and then she's going to finish off. So Lauren, I'll just make the slides go forward, and let me know when you want me to change the slides. I will just go through the quick learning objectives. I know that Athena had shared these, but really the goal of today is to sort of just start with a bit of a background on describing some of the specific survivorship challenges that AYAs face. Then we're gonna, I'm gonna jump in then and talk a little bit about how what our program is like, our Cancer Rehabilitation Survivorship Program, just give an orientation to that here, and then talk about a needs assessment that we did with AYAs to help inform the development of this program. And then Lauren will finish off talking about the development of the program and the piloting of an AYA-specific rehab program that we have here. Okay, so Lauren, I'll hand it over to you.
Okay, great, thank you. So first, yeah, like Jennifer said, I'm just going to provide a bit of background on AYA supportive care needs. So cancer is the leading disease-related cause of death in adolescents and young adults, also known as AYAs. But due to advances in cancer treatments in North America, the overall 5-year survival rate is now over 80%. And this, in combination with their young age, results in a large proportion of AYA cancer patients becoming long-term survivors. And this has led to the advocacy for the development of specialized follow-up care and survivorship programs for the AYA population. The AYA phase of life is full of many changes, developments, and achievements, and the diagnosis and treatment of cancer at this time can delay important life milestones, including education, job attainment and career progression, and the establishment of partnerships and families. In addition to this, cancer treatment can result in physiological and psychological side effects that may persist after cancer treatment ends and can pose lifelong risk for the development of late adverse effects and impairment to quality of life. Next slide. A 2020 study by Dr. Jones and colleagues that examined the needs of 575 post-treatment Canadian AYA cancer survivors found that 88% reported at least one physical concern, 90% reported at least one emotional concern, and 79% reported at least one practical challenge. Despite this, only 43% of those reporting a concern sought help. And so when they were asked why they didn't seek help, common reasons included not wanting to ask, being told that it was normal to feel the way that they did, and embarrassment. Of those that did seek help, so of that 43%, 37% encountered difficulty obtaining assistance. Next. Despite calls to develop effective models to maximize post-treatment care for AYA cancer population, many survivorship issues continue to be poorly understood and managed. Further, adult cancer survivors have limited infrastructure or expertise to address the specific care needs of this patient population. So regardless of the substantial impact of cancer on this group, many AYAs report experiencing unmet needs both during and following their cancer care, as was demonstrated on the previous slide. Given these challenges, cancer rehabilitation plays an essential role in the support, monitoring, and maintenance of a patient's health following a cancer diagnosis, as it aims to enhance the quality of life and functional capacity of patients throughout their cancer journey. The overall benefits of cancer rehabilitation are well established, and they've been shown to improve the physical and psychological well-being of cancer survivors. However, the availability of programs tailored to meet the specific needs of AYAs remains limited. And the majority of AYA-specific programs have focused simply on one aspect of care needs, such as exercise-only interventions. And while this is important in its own right, addressing one aspect of care needs fails to address the wide scope of concerns faced by AY survivors. So it's important to recognize the gap in the current provision of cancer rehabilitation for AY survivors. And in response, multi-component AY-specific intervention studies should be implemented, assessed, developed, and reported.
Great, thanks for that great background, Lauren. And so I'm going to just switch gears a little bit here and talk a little bit about our program here at Princess Margaret, just to lay the context for this AYA program. So many of you are who are on the call here are from Princess Margaret or UHN or are familiar with our program. But for those of you who aren't, this is just a bit of background in terms of like where we're situated in the hospital. So we have a Department of Supportive Care at Princess Margaret, which is one of our four pillars of care, along with medical, surgical, and radiation oncology. And within the Department of Supportive Care, there are 3 divisions. So there's palliative care, psychosocial oncology, and then cancer rehab and survivorship. And then there's also a number of cross-cutting specialty programs, including the AYA program, the older adults oncology program, and the caregiver program. So this project is really a collaboration between our program, Cancer Rehabilitation Survivorship, and the AYA program. So just for you to understand what the AYA program does here at Princess Margaret. So the AYA program at Princess Margaret sees patients who are under the age of 40 and provides personalized supportive care to those patients. And these and addresses the concerns of the AYA patient population, including things like fertility, sexual health, return to work or school issues, and a big focus on peer support as well, and promoting wellness. And so there's development of education and support resources, opportunities to connect with others through like we have some cooking classes, different things like that, meetups. And then just identifying individual needs, and the goal is to try to identify these patients early on, so at diagnosis, and help to support them throughout their cancer journey at Princess Margaret. And there's a number of different people who are involved with the AYA program here at Princess Margaret. In terms of the Cancer Rehabilitation Survivorship program, we take a multidisciplinary approach and have a very, I think, comprehensive multidisciplinary team. So you'll see these are all the different disciplines that are involved in our team. So we have physiatry, we have 2 staff physiatrists as well as 3 fellows. We have physiotherapists, occupational therapists, a social worker, neuropsychologist, dietitians, massage therapists for lymphedema, and then a team of kinesiologists that do our exercise training. And we are a consultative program in that we don't see patients for a very long time, but we're very tailored and personalized and holistic, and we deliver care to all disease sites at Princess Margaret. And just for a sense of like the volume of patients that we see, so we see in 2022, we saw just over 1,600 new patient referrals to our program. We delivered over 11,000 patient visits to 6,000 unique patients. So large volumes of patients. We are an impairment-driven program, which means that patients are referred to us when they have a cancer-related impairment and related disability and functional deficits. So the primary reason that we're getting referrals for patients into our program are MSK issues, persistent fatigue at the end of treatment, lymphedema, or deconditioning and exercise. And this varies by disease site, obviously. So in terms of what we offer within our program, all patients coming in undergo a comprehensive assessment with a physiatrist as well as OT or PT. And then based on that assessment, a care plan that's very tailored to the patient, their needs and their goals is offered to them. So that care plan can include a number of different specialty consults or follow-ups. So this is just a list of different consults and follow-ups that we offer. So these, again, by patient, it'll depend. It's very tailored. So maybe a patient will see physio for MSK follow-up, but also OT for a return to work consult. And in addition to these follow-up consults, we also have a 8-week structured rehab program that we developed back in 2016 called the CARE program. So this is a structured 8-week program that's offered in a number of different iterations, and I'll just go through these in a minute. And this leads us then to our CARE AYA program. So the CARE program started as a group-based in-person program called CARE at Elixir. And this is, again, for patients that have identified cancer-related impairments and related disability. So most people coming in have either moderate to severe levels of disability are coming into our program. They've already undergone a comprehensive assessment with physiatry and physio or OT, and then are referred into this program and do an intake with a kinesiologist who does a fitness assessment with them and develops a tailored exercise prescription. So each person has their own exercise prescription that's developed for them. And then they go into the 8-week program. So for the in-person program, they're coming in once a week. They're doing group-based exercise. Well, they're warming up as a group, and then they have sort of stations and they're doing their own exercises. The kinesiologists are there, physiotherapists come in as well to consult. And then after the exercise class, they have a self-management class. And each week it's a different topic. These topics were chosen based on a needs assessment, a large needs assessment we did with cancer survivors to identify the most important topics for them. I do want to mention we also use some technology to support patients going through our program. So everybody is offered a Fitbit. So we use wearable technology to help with motivation. And we also use an app called PhysiTrack, where we can put in the patient's tailored exercise prescription. And this is supported with videos that patients can watch while they're at home. So the goal is not that they're just doing their exercises once a week at Elixir, but they're also doing those exercises at home. So following their exercise prescription. After the formal 8-week program is done, there's sort of a supported program that goes on after that, where they're doing their exercises at home. We follow up with them at 3 months, and then again at 6 months, we reassess them, update their exercise prescriptions at that point. I should also mention that everybody in our team is trained in motivational counseling and motivational interviewing. So everybody has undergone fairly rigorous training and ongoing supervision. And that behavior change approach is built into everything that we do from the moment that patients come into our program. So we are a clinical research program and have done a fair amount in terms of evaluating the different care streams. And I just want to show you a little bit of data from the CARE at Elixir data. So what we do generally is we prospectively consent people coming through our clinical program, which means that anybody coming into the program, we ask them that they be willing to share their research for their clinical data for research purposes. So this is more naturalistic research. It's not randomized controlled trials, although we are conducting those as well. But this is just data of patients coming through our program. So we don't have controls here. But this is on sort of 210 people who consented for us to use their data for research purposes. And our main outcome that we're measuring is WHO Disability Assessment Schedule 12-item version, which is a great measure to measure disability, and it has established cutoffs. So as you can see, most patients that are coming into the CARE program are either in this sort of blue, which is severe, or gray bar, which is mild levels of disability. And by the 8-week time period, we're seeing kind of a nice shifting, at least out of that severe group, and then a continuing of that shift down at 3 months of patients sort of moving out of severe, moving into moderate, or moving from moderate down to mild, which is really nice. And we're seeing a change in the overall mean values as well, which is quite significant. But we also look at things like fitness and strength. So we do 6-minute walk tests, we do the grip strength, and we see nice improvements in those outcomes as well. So on the 6-minute walk test and grip strength, we're seeing both statistically, but also clinically significant improvements in those outcomes, which are mostly happen in the first 8 weeks, but then maintained to the 3-month point, which is really nice. And then in terms of self-reported physical activity, we also see really nice gains, again, clinically and statistically significant gains. A little bit of a drop at 3 months, but mostly it's maintained, which is really nice. And then we also measure social difficulties. So this is showing people above and below cutoff on the social difficulties index. So at baseline, we're seeing about 43% of patients who are scoring above cutoff on the social difficulties, and this is down to about 27% at time 3. So again, another nice statistically significant change. And we've been sort of collecting this data on all of our different care streams, and I just want to finish by just talking about those different care streams. So as I mentioned, we started with Care Elixir, which is our group-based in-person program. But following the rollout of that, we did see that there were quite a few patients who we were recommending this program to who really weren't able to attend because of different reasons, whether it be, you know, some people don't want to do groups. Some people are working and they're not able to come during the day. Some people have childcare issues. Some people are actually just have too many side effects to be able to come into the hospital and are too tired of those types of things. So for that reason, we took our Care at Elixir program and translated it to a virtual program called Care at Home. And that's a individual delivered program where patients come in, have their assessment, but then are registered to the online program. And it's a supported program in that we don't just sort of send them home to do the program, but we also have virtual video check-ins with them once a week. We can monitor their Fitbit in real time using we can pull that data in real time so the kinesiologists can see that, and when they have their check-ins can see how patients are doing. So we were really lucky that we had that program in place, and we have e-modules as well to provide the education support. We were very lucky to have that in place prior to COVID. So during COVID, we had already a nice virtual program in place. And at the same time that we developed Care at Home, we also developed a stream for patients with advanced cancer. So the Care at Elixir and Care at Home programs were very much positioned as recovery programs focused on recovery and transition back to life after cancer. But for patients with metastatic disease, the focus is not necessarily recovery, but maintenance of function and maintenance of quality of life. And we were receiving more and more referrals into our program of patients who had advanced cancer. As you know, people are living much longer with advanced cancer, and it can be managed pretty much as a chronic illness for some patients, living for many decades. So these patients historically haven't necessarily been offered cancer rehabilitation or our services, and so we created a stream specially for those. And in order to do that, we did like what we did when we started our original care program. We did a needs assessment with palliative patients coming into the palliative program and asked them about their topics of interest, and then tailored the program for the Care Advanced Cancer population. And I should mention that, and then we now have a virtual program for that. But I should mention also that we have a team grant, and we are doing a phase 2 trial with UBC, led by Dr. David Langelier and Kristen Campbell, to evaluate the Care AC program. We also in 2021 developed a care program for the allo-BMT population, and really this took all the elements of the care program and sort of stretched them out over a 6-month period, and we've just finished a phase 2 trial of that, and that is a publication that is just getting submitted. So then that leads us to our Care AYA program, and I will start by just talking about the reason why we decided to develop a Care AYA program, and then talk about our needs assessment. So the Care AYA program was developed because, just like with our AC program, we were seeing an increasing number of patients that were getting referred to our program who were under the age of 40. And for many of them, the feedback was that they didn't necessarily feel comfortable, or their preference was that they would like to be in groups with their own peers. And we were also getting this feedback from the clinical team too, saying we're seeing so many AYAs coming into the program now. It would be great if we could have some tailored programming for this patient population. So in order to do this, as you see, we always sort of start with these needs assessments. And so last summer, we had a summer student that helped us do a needs assessment, looking at what are the specific needs of the AYA population, with the goal of tailoring and adapting the care program. So the objective was really to gather feedback from AYA patients on their preferred format, method of delivery, and topics of interest related to cancer rehabilitation. And so we did a survey on REDCap and contacted AYAs, advertised the survey through the AYA program here, their newsletter, as well as on social media, and then analyzed the results. And really what we were looking at were what are the topics of interest, again, what is the sort of program structure and opportunities for them to provide other feedback to us. So we had 72 responses, which was quite nice over a very short period of time. For the most part, we had patients who were currently undergoing treatment. That was about 85%. Majority of them were in this sort of older age group of AYA, so in that 30 to 39 year age group. So that was about 80% of the respondents. And also we had many more women than men responding. So in terms of the program topics, and they were sort of rating them on a scale of 1 to 5, the most highly rated ones were physical activity, fear of recurrence, managing emotions, hormone changes, diet, relaxation, mindfulness. But you'll see that there's interest basically in all of these things. And what I've done here is I've put an asterisk after the topics that were topics that are already included in our care program. So things that we already sort of were including. But the things that don't have an asterisk are topics that they identified that were not already in the care program, and ones that we wanted to consider adding into the AYA tailored program. So really, fear of cancer recurrence, as many of you know, for AYAs is particularly high for this population. And so that was something that, you know, they really wanted to include it. Hormone and body image issues was another thing. And then a focus on sort of return to work and return to school was another one. So we did some sort of analysis looking whether there were any differences between men and women. And so men rated sort of body image and hormone changes more important than men. And our younger respondents were more interested in finances compared to the older respondents. In terms of program delivery, most people were saying that they would like a program that's either sort of 8 weeks to 12 weeks, which works out really nicely since our program is 8 weeks. But we had other people who said other things. You know, some people said they would want it to have it during treatment, that they would like it more frequently earlier, and then sort of like a little bit more spaced out later on. Some people said they want a 1-year program or a 2-year program, which just logistically we wouldn't be able to do, but it does. But we do have great community programs where we can transition our patients to those types of programs that we could provide support for that amount of time. And then in terms of the lengths of sessions, so people said that they would be willing to participate in a program that was either 1 to 2 hours, and there was less interest in things that were a lot longer than that. And 1 time a week was the preferred time frequency. And then we asked them time of day. So most people sort of said either morning. It was a scattering. So some people liked the morning, some people said earlier afternoon, or early evening. But it seemed like morning and early afternoon had the highest preference. And then in terms of format, there was more interest in person than online, but there was lots of interest in this idea of a hybrid. So offering the option to do either in person or online. So that was something that was new for us because we haven't ever really considered doing something in hybrid before. So just in summary, the results of this needs assessment were really helpful for us to sort of identify some of the distinct information needs that this population needs. So highlighting fear of cancer recurrence, body image, sexual health, and hormone changes, as well as return to work and school. And it looked like most people preferred programs that were 8 weeks, once a week. And there was this real interest in this idea of having a hybrid delivery where people could either join in person or online, whatever worked with them that week, I guess. So I will now hand it over to Lauren to talk about what we've done since that needs assessment.
Okay, so for some of you, this presentation is going to be quite familiar, but I'm going to be presenting on a pilot study. So CRS at Princess Margaret currently receives approximately 200 AYA referrals per year, And although these participants can be involved in our pre-existing programs, as previously highlighted, they have their own unique set of needs that need to be addressed. And also there needs to be a more life stage appropriate approach to the content, and also an opportunity for them to engage with their peers. So in response, we modified the current care program and developed a tailored care program specifically for AYA survivors. These modifications were based on the needs assessment survey that Jennifer previously went over. And we also formed a multidisciplinary AYA working group. And then I also received external input from the CRS team, including the class instructors, and from the AYA program at Princess Margaret. Next. So these are the members of our multidisciplinary expert working group that collaborated to modify the care program for the AYA population. Next. So what modifications were made? In the group-based exercise class for the CARE AYA program, we included discussions on new ways of exercising. So for example, one week they talk about supersetting, what it is, how to do it, and what are the benefits. And then on days that they discuss these different forms of exercise, the participants can opt to complete that exercise in the class with the help of the kinesiologists. And the original CARE program focuses on circuit training alone. And we decided to incorporate the different forms of exercise because the kinesiologists were reporting that patients of this age tended to get a bit bored of circuit training. And then we're asking them questions like, what is HIIT? How do I do HIIT or supersetting? We also tailored the content of the education classes. So as Jennifer presented, the second most requested topic behind physical activity was fear of cancer recurrence. And this was something that was not originally part of the CARE curriculum. And so we decided to incorporate this into our managing our emotions class. Another example is in connecting with others. We included discussions on changing relationships, dating, losing friendships, and how to set boundaries, particularly with parents in this population. And then also important to note, we included post-class evaluations and post-program evaluations. So the objectives of the CARE at Elixir AYA study are to assess the feasibility and acceptability of the program and to obtain preliminary estimates of the program's effects on disability, physical functioning, and quality of life. And I'll break down these objectives a little bit later on in the presentation. So we'll be running 4 groups of 6 to 12 participants, which results in a total sample size of 24 to 48 participants. Data will be collected at 3 different time points, and participants will be asked to provide informed consent regarding the use of their data for research purposes. If an individual decides not to consent to the study, they can still participate in the CARE program. So our referrals come from CRS, and Jennifer previously went over the referral process for the CARE programs. And the only additional criteria for referrals to CARE AYA is that the patient must be 18 to 39 at the time. They must have early stage cancer, and they cannot have a planned surgery during program duration. Patients with advanced cancer can be referred to our CARE Advanced Cancer program. And from here, they'll be scheduled for a fitness assessment. Next slide. So prior to the initiation of the CARE AYA program, the participants will undergo a fitness assessment with a registered kinesiologist, and they'll also receive an individualized exercise plan. So the fitness assessments include anthropometric data, cardiovascular screening, balance is measured for safety reasons to assess fall risk, grip strength, and then the 6-minute walking test is used to assess aerobic fitness. Following their assessment, the kinesiologist will prescribe an individualized exercise plan, which includes moderate intensity aerobic training at least 3 times per week, and then resistance training at least 2 days per week. And this is as per the ACSM guidelines for cancer survivors. And they will also be provided with access to the platform PhysiTrack here, where they can view and track their individualized exercise plan. And if interested, they can be provided a Fitbit device. So the CARE AYA program is operated similarly to the other CARE programs with the individualized exercise plan, and then 8 weeks of 1.5 hour self-management education classes and 1 hour of group-based exercise. The education classes run weekly for 8 weeks, and each class is an hour and a half, and it's delivered by specialized instructors, including social workers, occupational therapists, kinesiologists, etc. And this outlines the classes in no particular order besides the first and the last class. On the same day as the education classes, participants will join a group-based exercise class led by our kinesiologist and a physiotherapist. And this class runs weekly for 1 hour, and it really gives an opportunity for the participants to complete their exercise plan in a safe environment, ask the kinesiologist any questions that they might have, and also to progress their exercise plan. The class will start with an educational talk for approximately 10 minutes. And here the kinesiologist will discuss things like breathing during exercises, what to eat before and after exercise. And as I previously mentioned in the CARE AYA program, they'll be discussing different forms of exercise. And then they will complete a 5 to 10 minute circuit warm-up. And then for 30 minutes, they will do their own individual exercise plan. And this is followed by a group cool down and stretch. These in-person classes really give an opportunity for participants to progress their exercise plan. So they use rate of perceived exertion, or an RPE scale, and heart rate zones to assess the difficulty of exercises. And then once the participant feels that the exercise is somewhat easy, the kinesiologist will help them progress their exercise. But it's also important to note that participants will learn how to progress exercises on their own halfway through the program. So the study data will be collected at baseline, post-intervention, so following the 8-week program, and then 3 months post-intervention. Participant reported outcomes include the HUDAS, the short form health survey, the social difficulties inventory, the generalized anxiety disorder questionnaire, and the Goat and Shepherd leisure time physical activity questionnaire. And I previously went over the fitness assessments, but they're listed on the slide once again. And as I mentioned, participants, no, sorry, Jennifer, go back. As I mentioned, participants will need to provide informed consent regarding the use of their data from these assessments for research purposes. And then also there is the participants have the option to consent to a qualitative interview 3 months post-intervention. And so we'll just ask them questions about their experience in the program and opportunities for program improvement. Also not mentioned here is that there are 2 monthly follow-up calls with the kinesiologist and the participant, 1 month post-program and 2 months post-program. And this is just used for motivation, and no data is collected at these times. And any adverse events resulting from the intervention or study procedures will be scored on the CTCAE. Now you can go to the next slide. I mentioned how the objectives of this study are to assess the feasibility and acceptability of the program. So to break that down a little bit, the feasibility will be assessed using participation rates, meaning that the number of participants who were referred to the program compared to the number of participants who completed the baseline assessment. Retention rates, meaning the number of participants who complete the 8-week assessment and also the 3 months post-intervention. And then program adherence will be measured using the exercise and education class attendance. In accordance with the guidelines for pilot studies, the objectives for each feasibility outcome were set using relevant literature. So adequate participation will be defined as 60% of eligible participants. Adequate retention will be 70% for both the T1 and T2 time points. And then program adherence is 70% attendance in the education and exercise classes. The acceptability of the program will be assessed using the semi-structured qualitative interviews and also the post-class and post-program evaluation forms. And then the secondary outcomes are the exploratory clinical outcomes, and it includes the analysis of data from the questionnaires and the fitness assessments to obtain preliminary effects of the program's preliminary estimates of the program's effects on disability, physical functioning, and quality of life. So here I just kind of outline the acceptability measures in more detail. So I have some example questions from the interviews. So for example, participants will be asked, do you feel the CARE AYA program appropriately and successfully address the needs of AYA participants? And then we also have the post-class education evaluation, and we have a post-program evaluation specific to the education sessions and then specific to the exercise sessions. So in May to July, we ran our first group. So we originally had 9 participants enrolled. 1 participant dropped out before program initiation. 1 participant was disenrolled due to lack of attendance, and 1 participant did not consent to data collection. And so we had 6 participants who were part of the study. These were all female participants in this group, and the mean age was 31.6. And this mean age is consistent with other AY cancer rehab interventions. And as we saw in the needs assessment survey, it seems like most studies have a hard time engaging that younger AYA population. Next. So here I have our interim feasibility results. So far, we have a 83% retention rate, as 5 out of 6 participants completed both the baseline and the T1 assessments. And we're still finishing up the T2 or post 3-month intervention assessments. And regardless, this is above our 70% objective. And then we had 71% adherence to the exercise sessions and 73% adherence to the education classes. And once again, this is above our 70% objective for program adherence. So the interim results of acceptability were measured using the weekly and end of program evaluations. And this is because I haven't completed the qualitative interviews yet at T2. And so this was separated into benefits, facilitators, drawbacks, and barriers. So under benefits, participants felt that the program and its tools were useful. Being in a group with their peers made them feel like they were not alone. They found that the program improved their self-esteem, particularly their self-esteem with exercising. And also they found the program to be motivational and encouraging. A few facilitators to these benefits are the personalized exercise plan, the supportive staff, and access to helpful resources. A drawback to this program was that because it is a group-based program, the information is not always applicable to every single one of the group members because there are varying information needs. And then a few barriers to program attendance and participation were identified, including the program timing. So participants felt that the program was run too early. For the first group, it was at 9 a.m. There was issues with transportation. Some participants felt that more interactive components in the classes could increase engagement. And lastly, symptom burden impacted attendance as well. So here I have some direct participant quotes. So I'm just going to read one of them. Because of Elixir, I am now more confident when I walk, do chores, etc. Thank you for teaching me so much valuable stuff, from the education sessions to the workouts, because I will carry them all through my life. So following the first group, we decided to make some more changes. So this is based on the feedback from the first group members, the feedback from our instructors, but also that original needs assessment survey. We had some changes that we wanted to make from that survey, but we decided to hold off for that first group, see how it went, and then implement them for the second group. So mainly this is that we decided to do a hybrid education and in-person exercise. And this is because it was heavily requested on the needs assessment survey. I think it was like 69% of participants. And also the participants from our last group requested this as well. So each week, the classes will continue to run in person. However, if a participant is unable to make it one week, say, for example, they're sick, they can contact Elixir and they will be sent a link to join the education class virtually. And so we still encourage in-person attendance, but we just wanted to provide this option to our participants. Another change is the later class timing. And so the second group ran at 9:30 and the third group and fourth group are running in the afternoon. We also increased the interactivity of the classes, so more discussions, icebreakers, etc. And we further tailored the content based on the group feedback. For the exercise classes, the kinesiologist will be discussing Fitbit communities and challenges as a way to kind of increase the use of the Fitbit as a behavioral tool. And also kind of a fun one is that they are asking the participants to request songs to add to a workout playlist. And this is just a way to increase engagement and also sort of act as an icebreaker between the group members. And lastly, we are emailing the class resources to the participants at the start of the week, unless printed copies are requested by the participant. And so this is to reduce waste, provide participants with the resources in a format that they tend to prefer. And it also serves as a reminder each week of the upcoming class. Next. So we're just finishing up our second group. We had 9 participants. 1 participant did not have a cancer diagnosis and therefore was ineligible for the study. And 1 participant was removed for personal health reasons. And so we had 4 male participants and 4 female participants. We did make an exception to include a 42-year-old in this group. Next. So right now, as I mentioned, we're just finishing up group 2. We just had our last class yesterday. And then we have group 3 beginning next week. And in January, we will be running our 4th group. And so recruitment will continue all the way up until that 4th group. Data collection will run all the way up until May when group 4 completes their T2 assessments. And data analysis will begin when the first group completes their qualitative interviews, which I'm just working on right now. So yeah, thank you for listening to the pilot study and how we're kind of hoping to meet the needs of adolescents and young adults. And I hope that you found this information helpful.
Great job, Lauren. So I am also moderating today since we don't have a moderator. So I'll moderate ourselves. So I'm happy to open it up for questions,